We're just let me just show you a couple of slides about why coagulopathy is so bad. And all of you know this because all of you take care of these folks, both in the trauma setting and then in the ICU setting. But here's a good graph right here. Do you guys know what ISS is? ISS is called Injury Severity Scale. And we assess that by how injured the patient is in multiple areas. Head, chest, belly, extremities, and that gives you an injury severity scale. 20 is kind of our cutoff for really, 20 to 25, really injured versus not so injured. So you can see that the more injured a patient is, the chances are that they're going to have higher coagulopathy. So 0 and 75 is lethal. You can see coagulopathy goes up a great deal. So coagulopathy is pretty important. Oh, see, you sat in front. Now, look at mortality in coagulopathy. This is based on injury severity here. And the black is coagulopathy. If you have a coagulopathy, the chances of you dying are a great deal more, right? So here's the non-coagulopathic patient, and the same injury severity for the coagulopathic patient almost doubles your mortality, all right? So coagulopathy is important, and for years we use INR, partial prothrombin time or pro time, and that gives us some indication. But now along comes this TEG, which actually has been around for a long, long time, but only recently are we starting to using it in trauma. And I'm going to give you a personal story of why I could be rich and famous, but I'm not. And I'll tell you about that in a second. Maybe not rich, but definitely famous. So there are obviously lots of things that we used to use for patients that are coagulopathic. 7A, factor 7, which we've used in the past. We're now using more and more prothrombin complex, which a lot of you are very familiar with. And as you know, we're trying to be more into a 1-to-1 transfusion ratio. And again, that's to prevent this thing right here that you see. Coagulopathic patients die more. All right? It's not that intuitively it makes sense, but practice-wise, it took a long time to get to this position, almost 10 years. Now, do you guys remember this from nursing school and basic science? All that junk. Don't worry about it, because even though there's a lot of this junk that goes on, it's a little bit more complicated than that, but it's a nice way to remember things. The bottom line is that there are a lot of steps to a patient becoming hypocoagulable. The steps can include all these coagulation factors, and again, prothrombin complex attacks many of these, platelets, okay, which is part of this, and also fibrinogen, which is part of this too, and fibrin. All right, so there's a lot of stuff that goes on. And the TEG helps us maybe delineate which ones are actually the problem here and how we can help. And the other thing I want you to remember is, once you actually form the fibrin clot, all right, there's also something else that happens, and that fibrin clot can actually be broken down. Okay, and there's actually that fibrinolysis that can happen. And that's part of the TEG as well, and some other therapies that we've been using that some of you may have seen in the last few years. This is what a kind of a portable TEG machine looks like. And there's lots of different TEG machines out there. But this is kind of what it looks like. It's pretty small and it's pretty simple. I want you to pay attention to these cylinders down here. All right, and I'll show you why exactly these cylinders may have how they work and how the actual TEG works. Because a lot of you think, oh, TEG, get blood and put it in and magically we get a number or a graph. But it's actually a pretty simple concept. This is a patent. It was patented in the early 80s actually. So this is not something that's new. It's been around for 30 plus years. And I'm making this really, really simple. Remember that little cylinder I showed you in the TEG, that metallic cylinder? Well, that's basically what this cylinder is here. The number 13 is corresponding to the blood. And in this cylinder, there's a rod, and that's connected here. And when you put the blood in, and not a lot of blood, but when you put the blood in, the cylinder basically spins around back and forth, all right? And as it's spinning around, light is shining through. And as the cylinder is spinning around, as clot begins to develop, you get a different bit of refraction from the light, and you get a little bit more tension on the actual cylinder. So it's really watching the clot form and feeling that clot, when it was blood, now becomes thicker and thicker, becomes clot, how the tension of that clot differs. That's kind of how a TEG works. There's a lot more kind of biophysics behind it that I'm not very up to speed on, but that's kind of the scenario how things work. Okay, so the rotating pin is happening, blood is forming and clot is forming. There's this light that's actually rotating the pin and feeling the tension on the light or feeling the resistance as the clot begins to develop. That's then picked up by a detector, and somehow through the magic of ones and zeros, it goes into a computer, and then we start to get the actual TEG readout. All right, it takes about 20 to 30 minutes to actually everything to happen. Does this make sense to everyone? Okay, so that's the magic of a TEG. That's all it is. It's just a ball and a pin. And as the clot forms, the pin gets more resistance, and we start to read that, and that's how the clot develops. And that's how the actual readout of the TEG develops. So this is what we see on the computer screen. And I'm going to end with a few slides of actual UCSD patients, and we're all going to interpret what the TEG is, okay? So this is what the TEG is. And the blood is spinning. The x-axis is time, okay? And this axis here is the actual clot developing. So you see this line right here? Okay, that's called the R time, and we'll talk a little bit about that. And then do you see this line, how it fans out into two lines? All right, that's what's going to actually be ultimately deciding what the clot strength is. And it does that by the angle of this line, and then how wide this line is here. And that's called the maximum amplitude, or the MA. And we'll talk a little bit about that and interpret tags. The only way to learn this is by interpreting tags. Okay, now, tags have been around for a long time, all right? And I trained at University of Pittsburgh, which was a very large transplant center. And the transplant folks, intraoperatively, used to use tags all the time. And one day I saw this machine here sitting in OR6, which at University of Pittsburgh was the main transplant room. And I'm like, what the heck is that? And then they'd show me, oh, this is a TEG machine. I'm like, oh, that's interesting. And I thought to myself, why the hell aren't we using this in trauma? All right, that was in 1999, 2000. Had I actually taken that as a resident to the next level and actually doing studies on it, I would have been super famous. Because people are using that now in the last 3 to 5 years. I could have done it 10 years ago and been super famous. But it goes to show you that anytime you have an idea, damn it, act on the idea. It doesn't take a whole lot. Just act on it. It takes something, you can even patent it. Just write it down as a patent. And so nurses that have ideas for improvement in nursing care, do it now. Don't wait. Don't wait. I'll wait now. Take the idea and make it happen.
UCSD will take it away from you.
No, absolutely not. So this is what you do. They don't. UCSD encourages this, all right? If you ever go to Torrey Pines Mesa, you see all these biotech companies. They're all UCSD spin-offs, every single one of them, or the majority of them. So what you do is you have to go through what's called the Technology Transfer Office at UCSD. Put in your idea, it's a page form, and then they'll actually send an agent down to see if your idea is actually patentable. And they'll help you get the patent for a percentage of the royalty. So if you become rich and famous, UCSD takes 5%. All right, what's 5% of 100 million? Give them 5 million, you have the 95 million in your pocket, done deal. All right, I'm making it simplified, but actually that is true, that UCSD has this tech transfer. So if you ever have an idea, honestly, and I'm being dead serious about this, it can be simply an idea of a little sheath over a catheter. A lot of this has been developed by nurses in the past, critical care nurses. Write that idea down, go to the tech transfer website, and I can help you actually go to that website. It's really easy. So if you have an idea now, do it right now. I won't take a cut at all. Gratis.
So what's your cut?
Nothing, zero. For the yes ma'am. I'm a vegetarian, doesn't matter. Yes ma'am.
Actually help you create the product?
They may not necessarily help you create the product, but they'll help you get the patent for that product. Then you can create it, and the School of Engineering at UCSD wants to do these projects with you. So,
And I'll get the money?
well, if you're able to sell it, yeah. All right, let's go back to tags. But remember that, and actually, folks like us, clinicians, and most importantly, nurses that are actually using your hands and doing these things and saying, God, blessed life would be so much easier if this was just the case. Write that down and patent that darn thing. I'm telling you, patent the thing. All right. It may not, but you know, it won't help. Unless you swing, you'll never get a hit. Okay, now, let's go back to this and let's look at the way the actual plot forms. This is what it all means, okay? Now, the R time, as I was mentioning here, is the time it takes for that blood to start clotting. All right, we'll talk a little bit about what that means clinically. Now, remember I told you about, as we start to get this curve, this double-branched curve, it can be very steep or it can be very long and narrow. And that's, of course, called the angle. So that's the angle here. The angle is very important as well. All right. Then, however wide it gets, that's called the MA, or the maximal amplitude, and that's clot strength. Now, eventually, like we said, all clots start to dissolve. And that's what's happening here. You have lysis. Okay, so the clot's starting to lyse. All right. What does this mean clinically? If we have an R time that's too long, that patient probably needs FFP. Okay? Because that's clot beginning to form. And clot beginning to form is in fact FFP, all right, which has the clot products, 10, 9, 12, 2 to some extent. The angle is the rapidity of clot formation, how quickly that clot forming. That generally is considered to be fibrinogen. So if the angle is really low, fibrinogen and FFP both, but the angle is mostly considered to be fibrinogen. And the MA, or the width of that clot on the TEG, is considered to be platelets. Finally, you've got the clot lysing. If the clot, if this line, these two lines, if they start to come together quickly, now we're starting to have clot lysis, so that clot's starting to break down, that's when we start to use agents like tranexamic acid or Amicar, because at that point, the patient is hyperlytic and they're breaking down clot, not just not being able to form it, but also breaking it down quickly. That's all it is, folks. There's nothing more. These are the only values we use. There's probably a whole other bunch of stuff in there. We don't, as clinicians and surgeons, we don't really look at that. We just look at these four angles. We look at R time, amplitude, MA, and in fact, is the clot lysing. That's it. That's all there is to it. So we're done. Go eat lunch. Okay?
So do you have numbers to say that
Okay,
you
so
think it's not-
now let's talk about the specifics and go over examples.
Okay.
All right. Now, there are numbers, but we don't really know the numbers per se. We do, but we look at mostly the normal values, and I'll show you some examples of that. Okay, now that you know what everything is, this is an example. These are just kind of drawings of TEGs. And let's talk about what this might mean. Okay? Someone tell me about this TEG. Let's look at the R time. Does that R time look normal to you? All right, that's actually a normal looking R time. All right, see how it's nice and short? And it'll be hard. Once we'll go over some other examples, we'll show you exactly what the normals are, and so you can get an idea of it. All right, that's actually a normal R time. Now look at this angle. See how remember we're starting to split the road? Look at the angle of the road splitting. Is it a sharp left turn, or is it a gradual left turn or right turn? That's pretty sharp. Is that good or bad?
Bad.
That's good. You want the clot to form quickly, right? You don't want you want the turn to be very nice and slow. You want the clot to go bam, clot immediately. If it takes too long, then the clot will take too long to form. All right? Now, does everyone understand the angle? We like that angle. All right? What about the maximal amplitude, the MA? How's that? That's nice and broad and thick, right? We like that. Now remember, we are mostly interested in clot forming. We are not so much interested in having too much clot, right? Now there are some disease processes where too much clot might be bad, but for the acutely bleeding trauma patient or the TBI patient, we want to see clot happening quickly. So for us, this is a normal and a good TEG. All right, and I'm not even going to talk about the hypercoagulable TEG. That's a different story, and frankly, we're not very good at that. We look at the normal TEG. Okay, so this is actually a normal TEG. Okay, now let's look at a little bit of an abnormal TEG. What do you guys think of the R time here? Really long. So what do you give a patient that has a very long R time? Right? Because the R time means the beginning of the clot to form. And if the patient doesn't have enough factors, whether it's because of dilutional, whether because it's DIC, it doesn't matter. You're going to have a prolonged R time. Therefore, we're going to say we need to give this patient a product. What do you guys think of the angle? It's not that sharp, right? And this could be a product of both fibrinogen and FFP. But I bet in this patient, FFP would probably work, all right? Because we are beginning to see at least something. So FFP also contributes to the angle as well. That's another factor that one has to know. And then finally, what do you guys think of the MA? It's actually not terrible, right? Look at that MA, look at that MA. It's not terrible. It might be a little bit lower than normal, but pretty decent. So maybe this patient could use some platelets, maybe not, but not a bad angle. Okay, let's look at this one. All right, that's kind of a weird one. By the way, let's go back here. What do you guys think of the fibrinolytic aspect? When is this road coming back together? It's not, right? So it's nice and thick and it's going to stay that way for a while. Okay, now, what do you guys think of the R time here? It's a little bit longer, right? So this patient's probably hypocoagulable. What do you guys think of the angle when the road's splitting? How sharp is the turn? It's pretty good, right? So I think the patient actually has pretty decent angle. Now this is the MA. All right, how are the platelets in this patient? It's not bad. Remember, MA is just a one-time, it's the maximal amplitude. So the maximum of this patient is pretty darn good. Uh-oh, what about the actual fibrinolysis of this patient? The road's starting to come together pretty quickly. What would this patient most likely benefit from? Tranexamic acid, TXA, and or Amicar. Something that's going to prevent the lysis. All right, does that make sense to everyone? Okay, great. All right, what about this one? What do you guys think of the R time? Really long. So this patient will probably need what? Probably lots of product, right? FFP. What do you guys think of the angle? It's very narrow. It's not nice and steep. This patient would probably also need fibrinogen. What about the maximum amplitude? It's very narrow. This patient definitely is going to need platelets as well. So this is a global hypocoagulable patient. Just things aren't really very good in this patient. So hence we have this very, very disturbing looking TEG. All right. Interestingly enough, the patient is not fibrinolytic. All right. They're not lysing clot because the maximal amplitude, even though it's blunted, is remaining steady for a consistent period of time. Okay, now let's look at some real patients that.
Where does FIBA factor the multi?
Prothrombin complex? Prothrombin complex is basically a substitute for FFP. It acts, because remember, it has the same products as FFP does. FFP has, I know all these factors are a jumble in all of our heads, but the way I remember FFP and the way I remember prothrombin complex, it's the factors that are dependent on the liver. Right? That's why Coumadin works. Coumadin works on the vitamin K dependent factors in the liver. And the mnemonic I use is 1972, 10, 9, 7, and 2. Prothrombin complex has 10, 9, 7, and 2. FFP has 10, 9, 7, and 2, but not a lot of 7. All right, it has a lot of 10, a decent amount of 9, and a decent amount of 2, but not a lot of 7. That's why prothrombin complex is probably better, especially in those patients that are on Coumadin, and especially those patients that are really hypocoagulated and are dying. All right, so we really like prothrombin complex because it works a little bit faster, and you don't have the problems with blood. Now, patients that are massively hemorrhaging, the FFP is very important because it actually also helps with the global hypovolemic status of the patient. Okay? Now, this is the TEG at UCSD. Someone help me interpret this. Monica, tell me what's going on with this patient. Break it down into the R, the angle, the MA, and the lysis. What's the R time look like?
I think the R time is okay, right?
Pretty darn good.
Yeah.
All right, what about the angle?
The angle's good.
Pretty darn good. Okay.
And the
MA?
MA looks to be good.
Great. So far, so good. And we don't know what the lysis pattern is, but it looks like it's pretty darn good. Okay, now, these are the numbers that we were talking about below. So in general, you want the R time between 5 and 10, and that's minutes. I'm pretty sure it's minutes. 5 and 10? Yeah, it is minutes. This R time's 3 point. That's pretty good, right? The angle, don't worry about the K, the angle is between 53 and 72. That's normal. We're actually above normal, 75.9. Remember, for us, that's a good thing. All right, we want patients to clot. The MA is between, the normal is between 50 and 70. We're right smack dab at 70. That's good. In fact, we're even bigger than normal. That's good for our folks. And we don't know about the lysis pattern yet. That's LY30. See that? That's the lysis. That's down the road. We don't know because we're not there yet. But I can presume this patient probably has a normal lysis pattern as well. All these other numbers are really not, frankly, important. Okay? Good job. So this patient's pretty normal TEG. All right. Now, this is actually a patient that, excuse me, that most of you know. Remember the patient that was transferred from last year who had the seatbelt that basically didn't make it, was in the ICU for a couple days? And all these different TEGs on here are a collection of different TEGs over a period of time. All right? So I want to highlight the green color, because see how this is all green? That's this TEG right here. All right? Now that you know what to look for, and now that you know what these values mean, I'd like someone for me to interpret this TEG. Colleen, you're in the back keeping warm. Tell me what these numbers mean. And just go step by step. R time, angle, MA, and lysis.
And you're looking at the green.
Let's look at the green, the same color this is. And so you can see this kind of aqua green right here. That's what I want you to look at. So this R time looks kind of normal, but not sure, but now you have a reference point to help you. So the R number is 11.6, and the normal range is between 2 and 8. What does that mean? It's a prolonged R time, right? Would this patient benefit from FFP? Probably, just given what we see here. Okay. Now let's look at the angle. A normal angle is between 55 and 78. This patient's angle is 23.8. You can actually see how it's all narrow. Is this patient angle normal or abnormal? What would this patient benefit from? Fibrinogen and FFP, right? Both. Most likely fibrinogen. Dana?
Is that cryo?
Now, cryo has 7 in it and fibrinogen in it. So yes, cryo is exactly what you need. However, there are also some products out there that are pure fibrinogen alone. We don't use a lot of it, all right? And that's basically recombinant fibrinogen. So that's right, Dana. It's going to be, in this case, it's going to be cryo. Okay? By the way, cryo also has what? Factor 7. And another factor that you may or may not have heard of, most of you have heard of it, called von Willebrand factor, VWF. Von Willebrand's factor. Okay? So cryo has some of that as well. So that could be helpful in a patient who's hypocoagulable. Good. So we've got this patient probably needs cryo / fibrinogen, probably needs FFP. Now let's look at the platelets. Here's the MA. Okay, hard to know if that's normal. By the way, see this dotted purple? That's considered to be a normal TEG. All right, so that kind of helps you. All right, so now we're actually below the MA. What do you think this patient might need? Platelets, right? So this patient needs everything. This patient needs, as you would expect in a severely ill patient, as this patient would need massive transfusion. Blood because of the blood loss, FFP because of hypocoagulability, and now we can help guide our FFP here. Okay? Now, what about this patient? Real patient. All right? What do you guys think of the R time? Normal. 5 to 10, normal R time. FFP is great. This patient's bleeding. And our knee-jerk reaction is, FFP, go. All right, just chill. We've got a TEG now. Let's look at this a little bit. R time looks normal. Okay, so FFP may not necessarily be beneficial. What about our angle? Angle looks pretty much normal. This patient's bleeding. You gotta give cryo, you gotta give fibrinogen. Wait a minute. The TEG helps us here. All right. What about our MA? Pretty much normal, okay? I mean, yeah, a little bit on the lower side, 47.5, but pretty much within the normal realm of expected. Now remember, the MA here is 31, all right? 51s are cut off for being normal. This case, it's pretty close, right? Excuse me. This case, it's pretty close. All right, in other words, yes, platelets can be given, especially in an acutely bleeding patient, but that's probably not the primary cause. What about the lysis? Now look at the lysis percentage. Normal is 0 to 8%. We're 52.8. Look at that road that's dividing come together quickly. What is this patient going to benefit from? Amicar or tranexamic acid. And this is where TEG can really, really be helpful. For the most part, prolonged R times will have a prolonged INR. All right. For the most part, we'll know about platelet consumption because we'll have a platelet count. But fibrinolysis is really, really best seen rapidly by TEG. And this is where TEG can be very helpful in the fibrinolysis. All right, so we have had patients that have received Amicar or tranexamic acid, and they do probably help with the bleeding. And this is where we can really see that and it can help us. All right, so that's why TEGs are probably important. There's some other things about TEGs that are also maybe helpful. There are some papers out there that show that we might be able to find out if a patient's going to have, looking in a crystal ball, have a DVT or not by their TEG profile. Remember how I was saying, don't worry about the really big MAs or the really steep angles. Well, maybe we should. Maybe those patients might need a little bit more Lovenox if after their acute resuscitation. You know, they've got a hip fracture, but their MA was huge. They might get a DVT because they have a high MA. Well, maybe we should give them more Lovenox. So those are the types of things that people are looking, including us at UCSD, investigating whether TEG can be helpful, not just for the acutely bleeding patient in terms of what products to give, but also for those patients that may actually have abnormal TEGs and what we can do about that down the road. Okay, so that's basically TEG in a nutshell, and that's frankly all we look at.
So we're not doing the Flavex assays?
Okay.
So because that machine's
Right.
a nightmare.
Right. Remember, TEG is only for normal blood. All right. There are specific TEG assays you can use for patients on Plavix and so forth, but right now TEG doesn't quantify for that. So the Plavix assay does help us still. If a patient has just a completely lopsided PRU or a normal PRU, remember, we worked the paper that came out 2 years ago, 30% of our patients reportedly on Plavix aren't even close to being on Plavix. So that's where the Plavix is helpful. The PRU, I have to look at the exact values. We used to look at the percent inhibition, but now it's spitting out a PRU. I'll touch base with Kevin. Kevin knows the latest numbers. But that helps us tremendously. So we look at the PRU numbers, we're like, oh, don't give them platelets. Even though they have a head weight, it doesn't matter because they're not on Plavix. Or not theoretically on Plavix. Maybe they're not taking it or maybe they're not effective.
So if the machine's broken, they tell it said send a TEG, it isn't really helping.
No, it doesn't unless you do a specific, platelet assay for the TEG, and we don't have that capability right now. Correct. TEG is for patients that aren't on medication. It's for patients that you're looking at their coagulation profile. Officially. Unofficially, people are using it for that as well. There's some other questions. Ma'am?
How are you using it since a treatment versus like the patient rolls into trauma versus the patient who's been
I'm sorry, I couldn't hear your question.
in the sense of like you're treating your patients after you get these taken back, are you doing it in, and when they roll into trauma, or are you doing it as they're admitted and
We probably do them too late, and I don't think we're doing them enough. And we've talked about that as a group. We should probably order them a lot sooner than we do. And we should probably order them a lot more as we're progressively resuscitating a patient who's bleeding.
don't they take a while to turn?
20 minutes about. 20 minutes for the TEG to actually work, to get the blood sample out and send it to the lab, add another 10 to 15 minutes. So probably 30 to 35 minutes.
Sending them more trauma.
Yeah, I think we're getting better at it. And it's just a question of using it more and being more comfortable with it. But from the nursing perspective, for you to remind us helps too. Say, hey, do you want to send the TEG off?
Yeah, but if a person's bleeding to death, you make assumptions. You make
We-
assumptions
we-
they need FFP or
Right, we go
and
and
you get
we get the blood and we get the TEG going as well to help us guide things. But as you know, we just keep going, and the massive transfusion protocol has been very helpful in that respect, for product at least. But this helps us kind of be a little bit more targeted when the patient is still in a hypocoagulable state. Maybe they're lysing, and the TEG can show us that, as you saw. Any other questions?
After you corrected whatever they needed on the TEG, how long is the next one?
I
For
don't-
example, they need FFP, I gave FFP, when should we check it again?
I don't know. I don't think anyone knows.
Okay.
I don't think anyone knows. Now, we do check it periodically, but we're just intuitively guessing. There's no real science to guide us in this respect. I think most of us, just like we check an INR after, we don't know, right? We give FFP, and we check an INR. Do we check it 30 minutes after, an hour after, 5 hours after? We really don't know. 6 hours after? The next day? We don't know. We just kind of intuitively say, let's just check it after the platelets are given. And you guys I think know better than we do. Most of you guys just wait. It'll be better in 20 minutes, 30 minutes, not now. And then we say, did you send off the INR? Yeah, I'm sending it off. So, but frankly speaking, that helps. And so we don't really know the direct answer to that question. But we do know that TEGs do improve as the patient improves coagulopathic-wise. Any other questions?
Can you tell how many units of FFP it work depending on the arm?
No, we can't. And we can say really long R time probably needs more FFP or prothrombic complex. Not so long of an R time, maybe not as much, but we don't really know the answer to that. Even with Coumadin and or an INR, we don't really know the answer to that. I mean, many of you have seen an INR correct immediately with 2 packs of 2 units of FFP from 5 to 1.3. Some of you have seen that it doesn't matter how much FFP you give, that INR remains prolonged. So, and there's a lot of patient factors, disease factors, indications vary, but that all makes a big difference.
Have you coordinated it with the results of the Quag?
We have not, and those are things that we're looking into. But that would be interesting to see. Okay, remember the INR was originally designed for one thing and one thing only: Coumadin. It wasn't designed for the way we use it clinically. It was designed for Coumadin because the PT, which is what you would look at for Coumadin, varied tremendously amongst institutions. So an INR laboratory-wise as a way to, it's an international normalized ratio is what it stands for. And that's why it was originally used. So there's a lot of play into this. We really don't know the right answers. And I don't think we'll ever know because patients differ tremendously in terms of their coagulation ability as well. So, but it gives us at least a baseline. And it gives us at least something to go by so we don't just willy-nilly give or not give product or prothrombin complex. At least we can somewhat target it accordingly. But we're working on it, you know, and we'll see what happens. Yes, ma'am.
How we get the paper report?
It comes out on the computer. So you know that the little trauma bay where we look at films, not the trauma bay, the little area just behind the nursing the unit clerk station, the doctor's area. One of the computers, if you're looking at the main PAC screen to the left, you'll see TEG is on there. TEG monitor's on there, and there's just a little. I should have actually brought a. Yeah, you just click on that icon, and then the patient name will come up, and it'll show you.
You always get the little paper thing.
Yeah, they fax
Right.
it.
They fax it.
Right, you can actually get it in real time as it's coming out and as the R is coming out, as the clot's developing. It's pretty cool. Maybe next time you do it, if you have time, you know, have one of the residents or the fellows open it up and show it to you. All right, anything else? Okay, thank you all.